Hey there. Welcome to the Pelvis Project podcast. I'm Megan.
And I'm Roxy. We're two pelvic health experts brought together by passion for our careers, entrepreneurship, motherhood, and the desire for intentional relationships.
Join us in our mission to spread pelvic floor awareness and start conversations surrounding the truth behind genuine health, imperfect wellness, and joyfully navigating life. We are so glad you are here with us.
Let's start the conversation. Megan, we're back. How are you?
Good. How are you?
Great. I'm excited about this episode. We've introduced each other, and now we're going to jump head first, and we're going to jump into the pelvic floor. Are you ready?
We are ready.
Great. Okay. So Megan, let's start out. I want you to familiarize us, give us a good, solid definition here to get this started. We're not messing around.
Yes. Okay. So what is pelvic rehabilitation? So this is going to be like your standard full of words. People are going to be like, okay, I still don't get it. So pelvic rehabilitation is a non-surgical approach to rehabilitation of dysfunction of the pelvis that contributes to bowel, bladder, sexual health, and pain complaints. Approaches may include behavioral strategies, manual therapies, modalities, therapeutic exercise, education, and functional retraining. And that's straight from our notes from a Herman and Wallace course. But you hear all that and you're like, okay, what does that mean? Those of us that are in the world of pelvic floor or PT, we know what manual therapies mean. We know what modalities mean. We know what therapeutic exercise means. But a lot of people and our patients don't know what that means. And they are also still left with, they get a referral to pelvic floor rehab. And if maybe they've done their research through, social media these days, people have an idea. But often we get people that are like, I didn't even know this was a thing. What's going to happen? And still, even for our support staff to explain is tough because they're not the one doing it. So let's kind of go through exactly what all that means, what the pelvic floor is, and at the end, what pelvic floor rehabilitation or PTOT really is. Because if we are thinking that it's just looking at the pelvis, then you are mistaken. And little nugget, if you've done pelvic floor therapy and that's all they looked at, maybe you need to go back.
Ooh, truth hurts sometimes, right?
It does. I mean, if you're doing great, then great. But there can be a lot of things that gets missed if all we look at is the pelvis. So, Roxy, let's go through and talk about, let's go through a few statistics for pelvic floor.
Sure. So did you know that pelvic floor disorders are stopping 46% of females from exercising?
That's a high number.
And that just is disorders. That's not just leakage. We think leakage automatically, but there's a lot more things in that also. Let me keep going. You want me to do another one?
Yes.
Okay. 49% of gym exercising women experience stress urinary incontinence where they leak when they are working out. And then last one that is really shocking to me, I think is an eye-opener, is 95% of women with low back pain have pelvic floor dysfunction.
Yeah, that number is really high. And we see so many women come in and we may say things like, do you have low back pain? They're like, oh yeah, I've had that forever. It's like, that's not part of this. We're like, yes, it is very well part of it. But I just want to circle back to the whole 46% of women, it's stopping, pelvic floor disorders are stopping from exercising, and 49% are leaking during exercise. So we think of those numbers that potentially that many women are limiting what they're doing activity-wise because of this issue. And we just know that the importance for cardiovascular health and bone density and all these things, especially for women as we age, that if we're having these quote unquote disorders of the pelvic floor, we are going to avoid things that make us uncomfortable. And those numbers are very, very high. And the frustrating part is it can be fixed. It can be helped. And we're still just trying to get more women to understand that. And for doctors to start asking women specifically if these things are happening, because often you still think it's normal. We'll go right into myths.
Yeah.
I've had kids, so it's normal to leak urine. No, it's not. It's common.
It's common, not normal. That's our soapbox.
Yes.
Let's just replace even gym. That's the research. Gym exercising women. What about moms that just want to be playful with their kids and they're like, oh, I'm going to pee my pants, So like gym exercising women, someone might say, I don't really go to the gym, so that doesn't apply to me. But no, that's just what the study was done on. We can generalize that though to women who are using their body every day, and that's where I think it hits home then of saying, ooh, I would like to play chase and tag and jump on the trampoline with my kids, but this is the problem.
Exactly. And for those of you that do think that you're leaking because, it's just because I'm getting older or I've had kids, it only happens during those times. We see 12-year-olds, we see 19-year-olds, we see very young individuals that have not had children leaking. And so we can talk more about that. So if you're like, oh, wow, mind blown, I didn't know that, because I have a lot of women like, oh, wow, really? I didn't realize that. Yeah. So it's not just because you've had kids. And then absolutely just kind of like echoing what you said, Roxy, working out looks so different for everybody. And a lot of my patients that are busy moms, we have to really get very creative on what exercise looks like for them. They're never stepping foot in a gym.
Sure.
It's stuff that we're doing at home and playing with their kids and different things that way. So yeah, it's just it is mind blowing. So that gives us some statistics and breaking some myths down that are common out there that have been embedded into our brains. So, but let's talk a little bit about next what some common signs of pelvic floor dysfunction might look like in an individual.
Sure. So obviously that we've already kind of talked about urinary incontinence where we're leaking pee. That just is the obvious one, but yet it's so overlooked too, like we just talked about. So that's an obvious one. Another one is frequency, where you're just running to the bathroom all the time and you're thinking, man, I have to go pee all the time. Or I feel like I have to pee and then I don't. I go sit on the toilet and I trickle a little bit and I felt like I was going to pee my pants and there was hardly anything there. So that's another sign that something's not right. Constipation's a big one.
Mm-hmm.
That's something, I don't know how many patients who are living a constipated life and don't know it because they've been constipated since they were a little kid. And so just no one's talking about what is healthy bowel. What's a healthy bowel life look like? Because if you aren't talking about it, then you think what is happening with you is what everyone is doing. And that's not the case. Let's see. How about like prolapse or this feeling of heaviness? That's common. Pelvic pain in general, like that could be anything. That could be, if we look at the umbrella of pelvic pain, that's not just pain in the vagina. That can be rectal pain. That can be abdominal pain. That can be pain in the groin, low back pain, like we talked about, tailbone pain. That kind of segues into the next one then is pain with intercourse. I know, Megan, you really touched on that in your interview of just that's one of your not favorites to treat, but just, a big one that's so impactful. So a couple more pain ones, like we talked about, low back pain, hip pain, tailbone pain. Those are all signs. And I bet a lot of us can say, oh yeah, I do have that sometimes or a lot of times. And so it's a lot more common, not normal, but common than maybe we give it credit for.
Mm-hmm. Okay. Yeah. So also too, just, talking on pelvic pain or pain with intercourse, what we've just listed off here is a very short list. The list of what we can treat is extensive. And I know that probably on your website, Roxy, and on mine, we have different sections and what that all can mean. Because gosh, you go into pregnancy and postpartum and pain, and we talk about vulvodynia and vaginismus, and we can talk more about what those diagnoses are. But at the end of the day, regardless of if you've had this diagnosis been given to you, it does fall into the umbrella of, pain. And so I think just knowing that if something we have mentioned resonates with you, or if you're like, well, I don't know, get your wheels turning, I encourage you to go and look at those lists, because still just realizing what we can help with. And like Roxy had mentioned, constipation, oh my goodness sakes. if I had a quarter for every time someone's like, oh yeah, but that's just me. I've been constipated my whole life. Like, whoa, let's back up. And then also too, this isn't a talk on pediatrics, but we're seeing more and more children with constipation and their pediatricians telling them, oh, it's okay. They'll grow out of it. And they will potentially have pain having a bowel movement, which then causes them to be scared because at that age, they don't have the capability to, think through the whole process. We know as adults, if it hurts, gosh, we know what that's like. So can you imagine how scary that is for a kid? So anyway, I'm getting on a soapbox here, but really it is an all-encompassing kind of care that we can give in pelvic health. So yeah, so those are definitely a lot of common signs that we see. But I could jump into what the pelvic floor actually is, because a lot of times people say like, gosh, I didn't even realize we had muscles down there. So the pelvic floor is a group of muscles that sits at the base of the pelvis, and it runs from each of your sits bones to your pubic bone back to your coccyx. So it really is a bowl of muscles, and it's very active. So the pelvic floor plays a vital role in many functions that we don't think about. So it's sphincteric, meaning it will hold back bladder or bowel movements. So you can decide when you want to go to the bathroom. Thank goodness for those muscles. It's supportive. It supports the pelvic organs. So we're thinking bladder, uterus, rectum, all those important players. It aids in sexual appreciation. So with orgasm, contract, relax. It's our deepest stabilizer. So our low back, our hips, and our pelvic girdle all work together. And then it acts as a sump pump and helps move lymph and fluid out of the pelvis. So it has some pretty important roles. And if everything's functioning correctly, we don't think much about it. But when one of those things isn't working right, Houston, we have a problem type of thing. So that is the pelvic floor. And I would encourage somebody, if you're still like, what? Boy, Google is a friend. Go find a picture and then you can know. But even the pictures, I feel like are a little misleading because you can't really, it doesn't show basically, the vagina is a tube of muscle. And so the pictures, it's hard to show that when we are actually doing any sort of internal work, when we're pressing on the walls of the vagina, that's like how we get to those muscles, which we can talk more about, like what all that treatment might look like. But I know some people, it sounds scary, but it's not.
Sure. And I would just add that I think I have a lot of patients that don't quite understand that men and women have a pelvic floor. And so all these apply to both males and females. There's minor differences. Obviously, our anatomy is different, but the generalization of the pelvic floor and the anatomy of the pelvic floor is overall generally the same, and it functions the same, for different purposes when it comes to more of the mechanics of things. But just right there, just know that if you're a female, your husbands have this too.
Yeah, I know. Go home and tell them that. So what we're going to do, though, is now we're going to kind of bring it back to what pelvic floor therapy really is. Because when we mentioned before that if you're just looking at the pelvis, that is only one piece of it. And it really is mind blowing when you realize your pelvic floor could actually be functioning very well, but it could be something else going on, like you're holding your breath and there's too much pressure coming down, or your ribs aren't moving. And so all the pressure goes down and causes you to leak. Like there's so many things. So we're going to kind of break that down. But I'll start with the first one of just the pelvic floor itself. And then Roxy we'll kind of go back and forth. But the pelvic floor itself, we talk about, muscles have strength and they have endurance. And so it is good for us to know how strong those muscles are. However, often we will tell people you could have somebody with a very weak pelvic floor. So we grade on a 0 to 5 scale. That's how we're taught as PTs for any muscle. You could have somebody come in with a 1 out of 5 strength, which is very weak, and not leak urine. And you can have somebody that comes in that you test them and they're a 4 out of 5 strength and they do leak urine. So for us as providers, yes, do I check strength? I do. Is that the only reason why you're leaking? No. Could it have nothing to do with it? Yes. Okay. And then same thing goes with endurance. So we have to look at coordination. How are the muscles working together with the core? How are you activating those muscles? When you activate them, is it a quick and then a quick drop? Or, like we look at all of that. Is it a smooth rise? Is it a quick drop? So yes, it gives us a ton of information, but now we're going to tell you guys a little bit more beyond what we look at outside of the pelvic floor.
Sure. Before I move on real quick, I just would add to that then what Megan just said is hopefully very affirming for anyone who has done the recommended amount of Kegels and not seen any change in their symptoms. Yeah. And so just know, like, if you feel like you've been doing everything you've been told, this is why that has been unsuccessful. And it's not because maybe you're doing anything wrong. And that's where we have to look at the whole person. And so we're going to continue on that, but just be affirmed that if you've been trying that and not failing, but just not seeing any change, that's why, because that's one piece and it's an important piece, but it's not the only thing.
Right. And you could have been somebody who's been told by their provider, well, just go home and do Kegels. And actually, you already have a strong pelvic floor. It could be that your pelvic floor is too tight and too contracted, that then it can't, when you do a quote unquote Kegel, it's not doing anything. It's making things worse. And if you have pain, you definitely aren't going to be somebody that's going to be giving Kegels. And I think everybody is well aware enough now that Kegels aren't the answer. Because our pelvic floor does not work in isolation. And so, like Roxy said, yeah, if you're somebody who's trying to treat yourself and you're like, well, I've done all these Kegels, we hear it all the time. And I'm just like, stop. You will get better without doing all of those.
Sure. So we're going to move on. The pelvic floor is the lens that we look at then the rest of the body through. And so the next, or not the next, but another big piece is just our overall alignment. If we look at our head, our shoulders, our upper back, our spine, this is where posture is a huge, huge influencer on how the pelvic floor is able to function. Our posture sets our pelvic floor up for success or for failure, and maybe not legitimate failure, but just for a lot of extra work. I mean, our bodies were created to work in a certain alignment. And when we throw that system, when we have poor posture, intentionally or unintentionally, I mean, usually it's not intentionally, but just poor posture in general, it just is a domino effect. And so we're going to look at that. And so if a lot of times we work on the spine, we work on, shoulder strength and stability to help us sit up tall, to help us be able to have that good overall quality alignment, because that sets the pelvic floor up for the treatment that it needs. And it makes it more, I guess, receptive, if we want to talk about it that way, of just establishes a better receptiveness in the pelvic floor for then the changes that we're going to, or the therapy that we're actually going to do to the pelvic floor can be very unsuccessful if our posture is poor. And so there you go. There's your low-hanging fruit for the day.
Yeah.
Start looking at your posture and you're automatically going to have a healthier pelvic floor.
That's right. That's right. Well, and again, with that too, if you are somebody who you have one hip that's tighter and maybe it's a little elevated and all of it seems a little quote unquote off, most of the time, if then we check the pelvic floor, that side of the pelvic floor is going to be tighter. And if one side is all wrenched and tight and the other side is doing its own thing, then you can see where the activation of the pelvic floor is off, the coordination is off. And like Roxy said, it doesn't set us up for a good foundation for the building blocks of rehab. So everybody sit up a little taller while they're listening, or stand 2 inches taller, pretend like you got a string on your head, because it definitely will make you feel better. So yes. Okay. So we talked about posture. Okay. So let's talk about the diaphragm. The diaphragm is my favorite muscle. So you may be asking yourself, what does this have to do with anything? Well, so the pelvic floor and the diaphragm are connected. So when we get a good inhale, so when we inhale, the pelvic floor lengthens. So as you inhale and the diaphragm drops, the pelvic floor drops with it and they work together. So they work synergistically. So pelvic floor lengthens. And as you exhale, pelvic floor comes back up. And that just happens naturally. But the issue is if you are somebody who you're always shallow breathing, and let's say that you have some other pelvic floor symptoms and they all compile on each other, and then we also are not breathing, that pelvic floor is not able to lengthen and move the way that we want it to. So one of the ways that we can allow movement through our pelvic floor for any of us is to work on breath work. And so if that's something that you haven't worked on in pelvic floor therapy, it's something that you should kind of ask, if you will. But yeah, so the diaphragm and the pelvic floor move together. And with that, we also need to be thinking about the rib cage. So often if we're somebody who we realize, oh, wow, I hold a lot of tension, I hardly ever take a deep breath, the rib cage isn't going to be moving either. So again, we want to look at how are the ribs moving? How is somebody breathing? Where's that restriction at? Often we'll have somebody take a deep breath in for us and their abdomen doesn't move at all. So when you take a breath in, your abdomen should rise. And often when people take a breath in, their chest rises up. And that just kind of leads us to also, if we want to take it down even a further rabbit hole of when we are doing our breath work, we teach it as 360 breathing. When we do that, you're activating that vagus nerve, and vagus nerve is the longest nerve in our body. It's called the wandering nerve or their mother nerve. And we are trying to tap into the autonomic system of rest and digest. So that parasympathetic system. And when we work on this breath work, not only are we helping to calm the nervous system, that helps that pelvic floor release better as well. If we are activated and we are in sympathetic state, which is fight or flight, we're chest breathing, it's shallow, that pelvic floor, there's tension there. So if you think about any time that you've been in some sort of like fight or flight situation, there's tension through your body, and that's also the pelvic floor. So when we're talking about the diaphragm and breathing, often we'll have somebody come in, and on that first visit, we may not be doing an internal exam on the first visit for whatever reason. And if we give breath work, often we'll have people come back that second visit and already notice a change in their symptoms that they're having just by having them start to breathe properly. Because not only are you getting lengthening through the pelvic floor with the diaphragm moving, but you're also calming the system down. Because if any woman has ever experienced pelvic floor issue, you worry, there's shame, there's all these things that go around with it. And that just causes that nervous system to upregulate as well. So obviously there's more that goes into all of this, but that's just like that in a little nutshell. So diaphragm. Yep. That's a good one.
Great. Okay. Next, we're going to keep moving down the abdominal balance, abdominals. So if we think of our trunk as a canister, the diaphragm's the top of the canister. The pelvic floor we've talked about also as the base, but the abdominals are the sides of that canister, that can of pop, that can of beans, however you want to look at it. And so the abdominal muscles, now this isn't like if you have a six pack or not, that's not what we're talking about here. We're really talking about stabilization here. The abdominals can be really good, even with a good layer of fat on the top of them. So don't worry about how it looks, anything like that. But that's what we're talking about, the abdominals and managing that pressure and how well the top, the sides, and the bottom of that canister all work together. And so the pelvic floor works with our abdominals. I think of them as little best friends running around together. And that pelvic floor contraction is pre-programmed to happen before abdominal pressure happens. And so when one's working well, the other's working well. When the other one isn't working well, it makes it very difficult then for that, then their counterpart to work well together. They're separate muscles, but they're little buddies running around together, and they want to be just, working together. And so a lot of times when we're born, when we're developing all the things, our abdominals just work how they're supposed to as stabilizers. And we don't teach our kids how to contract their abdominals very often. I mean, that's not like a normal part of parenting, thank goodness, right? But, through pregnancy or pain or, just stress, different things that our body lives through are the way that things work sometimes jump ship. And so when we're doing this work on anything really we're talking about, we're just reminding our body how it was created to function. And so we're going to come in and we're going to remind it, this is how you work. We just takes a little bit of re-education, a little bit of reminding. And so the abdomen, Megan talked about that diaphragm drops and so does the pelvic floor. It lengthens and then the pelvic floor lengthens. Well, at that same time, the abdominals have to lengthen. They have to absorb the shock. And so you think about when you cough or sneeze or even lift, we need those abdominal muscles also to be absorbing a little bit of shock there. So then it can rebound and strengthen and really be solid that way. That's where that pressure regulation happens. If you've ever coughed and sneezed and leaked a little bit, that's all that is it not all that is. That's a big chunk of that is just that pressure management. And our body isn't resilient enough to accommodate extra pressure that way. And so the abdominal cord, helping the abdominals and the pelvic floor remember how good a friendship they have and how well they can work together and coordinate. A lot of times it's just a coordination issue and our body really actually wants to be healthy. It wants to do that. Sometimes it just doesn't know how. And it's in that survival mode. It's just trying to survive. It's not trying to figure out how to fine tune these little muscles that used to work perfectly together. And so anyway, that's a big piece to it, is helping all those pieces coordinate. You can see how we're layering on and how this is more than just the pelvic floor. We're adding these layers, but it's so necessary. I think it's really beautiful as we look at just these pieces to see how our bodies were created. There's a lot of intention behind each piece in our body. And I think that's really beautiful. Even when we have dysfunction, our body works really well. It gets us out of bed and we go throughout our day, even in the midst of all this dysfunction that we're talking about today. So give your body a pat on the back, even if you're having struggles, is that it's still doing the best it can. And I think that's really beautiful too, that it's able to get us through those days. But we want to be better than just surviving. And Megan talked about why just surviving isn't good enough. And so bringing the abdominal balance and really regulating that pressure inside this whole canister is a huge piece to that.
Yeah. And I'll just say too, I know, Roxy, that you experience and do this as well with checking, but early on in my career, often I would just be like, okay, well, do a TA contraction for me. Let me see here. And I describe it to them, and I think some individuals, yeah, they got this. They're doing it just right. I mean, sometimes, it's those in the health or in the fitness industry too, that, everybody, or not even in the fitness industry, somebody looks really fit. Like, yeah, they're activating their TA correctly, but you cannot get by with a fake TA contraction if you have somebody do a TA contraction while you're doing an internal assessment. Because if we're doing an internal assessment and we say, okay, activate your TA, and suddenly you activate, but it wants to push our finger out, then that right there shows us where that miscoordination is happening. Because when you contract your TA, like Roxy said, it works together with the pelvic floor, and there's a pre-contraction of the pelvic floor prior. Everything should come up and in, and it stabilizes and supports. But if you go and do your TA contraction and it wants to push us out, then we know, okay, there's a misfire, and that's okay if that happens. And like Roxy said, our body is just trying to figure out what it can do to try to help and work the best it can. And sometimes that miscoordination could happen after pregnancy, and like it just never got relearned. It's pretty crazy. After pregnancy, you try to contract your core muscles. They've just been on a major stretch, and along the lines, something happens. But often all we have to do is give a little bit of cueing and somebody can get right back on track. And that's the cool thing also, is I think sometimes pelvic floor therapy is sold, especially from places that offer the devices, like the Kegel devices, that like the alternative is going to hours of physical therapy or occupational pelvic floor therapy. And that's just straight up not true, because sometimes it doesn't take very long at all. If someone has a simple miscoordination, and it takes a few visits to correct and move along your way in your life. So yeah, it's really beautiful the way that those two work together. Like Roxy said, our body is created, and to me, it's just like a symphony. Our hormones work as a symphony, our body and our muscles do the same thing. So Next, we're going to move on down. If you haven't noticed, we're kind of moving down the body a little bit, but which we'll kind of like circle back because we didn't talk about the jaw, but the glutes. So, and I'm just going to kind of do glutes and hips and all of it, just wrap that all up together. So, our glute muscles and our hip muscles, I like to say they're close cousins. They're all working together right there with the pelvic floor. And basically, the biggest thing that I think we need to know about this is if our glutes and our hips and those muscles are weak, the pelvic floor will start to become overactive because it needs to stabilize, and it's just doing its job on its merry way. And the hips and the glutes are like, well, we're tired, so I guess the pelvic floor can take over. And then that's where the dysfunction starts to lie down. So when we look at our hips and our glutes, one of the things that we focus on at some point in the rehab is strengthening so that that pelvic floor can get in a state where it doesn't feel like it needs to be overactive and it can get back online the way that it should be. And then everything can work synergistically together. And when we talk about hips, man, we've got rotators and adductors, and we're talking all of those muscles. So Roxy, why don't you finish us out with the foot at the bottom, and then maybe just talk a minute about the jaw and the fascial line.
Sure. So the feet, we're going clear down out of the bottom, and the feet seem very far away from the pelvic floor, but this is our foundation. It's what we stand on. And Megan just talked about the hips. Well, the hips a lot of times are set up by the feet. And so if our feet are weak, if our ankles are stiff, if we have pain in a foot, there's lots of things that when the feet aren't setting up a good solid base for us to work off of, then it throws off the whole chain up above it. And so we definitely are looking at the feet. We're correcting dysfunction at the feet. And that can get thrown by weight, if it's carrying around extra weight, whether that's pregnancy, whether that's just a bad season of life or where we've put on a couple extra pounds, right? It can be an injury, there's a lot of things that mess with our feet. It can just be, overuse over years, of where the feet just start to wear down or they start to accommodate to positions or movements that we're doing. And so anyway, that seems like a long ways away from our pelvic floor, but it's very, very important as we look at our patient's whole body and how everything is influencing each other. And then I'll just jump back up to the jaw. One thing about the jaw is that there's a lot of that, again, feels a long way from the pelvic floor, but a lot of tension in the jaw and clenching of the jaw. Think of when you're angry or you're anxious or you're stressed. A lot of times that jaw tenses shut. And the research is showing us more and more that the people who were wondering about it are actually spot on correct, that influences the pelvic floor, and people who have jaw pain and have clenched their teeth and have clenched their jaw are having a lot of pelvic floor dysfunction. And it's just a little indicator of maybe what the nervous system is actually doing. And if the nervous system is not on point, and if it's surviving and the jaw is surviving, then the pelvic floor also is off kilter as well. And then from our throat clear down the front of our body, if you just imagine a big string from the front of your throat, clear down the front of your body into your abdomen, down to your pelvic floor, and then even into the inner thighs, that's a whole fascial connection. And fascia is kind of a funky part of our body. And I think it's really cool. It's kind of a hard thing to grasp, but it's not a muscle. It's more of connective tissue. But if there's tension along that anywhere, that can set the pelvic floor up for failure again. And we're not making this up. But, any kind of scarring in the abdomen, it sounds like we're just scraping, it sounds like we're just saying, oh, everything can. But really, if we just look at our body as a whole unit, and nothing's exempt from influence. And I just think about, in life, we say every decision you make has some kind of result, some kind of effect. And that's the same thing in our body. When something starts to go wrong in one area of the body, it has an effect that starts to domino and starts to ripple into other areas. And so that front fascial line, we cannot ignore. That's a whole nother podcast, but it just goes to show that there's so much connection there. It goes right back to posture, goes right back to the diaphragm, the abdominals, the pelvic floor, the hips. That's all connected by this fascial connection that it helps make our bodies. It helps keep us all connected. So we aren't just floating limbs of mass of arm here, head here,
Yes. I wish that sometimes that the podcast is a video, so you can look up and show the fascial slings in our system. And really, if you think about it, like if you have your shirt on right now and you grab the upper right hand corner of it and you twist your shirt and you see where your shirt pulls, that's pretty much what happens to the fascia. And we see so many people come in here, and as we're talking about their pelvic floor and we're starting, we'll ask them like, oh, do you clench your jaw? Do you have jaw pain? Oh yeah, actually, I've been fighting this like TMJ. And as we're working on their pelvic floor, we'll touch back base on that. How's your jaw been doing? Actually, it's doing a lot better. And so that's not to say it's the only thing that fixes TMJ, but it's a big player. And I'm loving these conversations that we're starting to have with myofunctional therapists and dentists. And it really is a cool thing, and how they can work together as at least a piece of the treatment. So if someone's just getting, I know this isn't a podcast about TMJ, but if you're going and getting that like, maybe that's another piece too that can be added in. And that's maybe just potentially even just like the breath work that we teach. But anyway, we digress. I actually was just cupping somebody's jaw the other day because she's there for pelvic floor, but her jaw, she had something happen and all the things. So it really is, if you haven't noticed from this conversation, pelvic floor therapy is a full body holistic approach to treatment. And, we could dive even deeper. I recently went to a course on a visceral work for the fertility patient. And so visceral work is, we're talking about organs and how organs move against one another. And if there's restriction there, what that can do and why that's happening and why it's important that we improve that. Because then that starts to quietly affect the function of the organs. So I guess I would just encourage everybody that if you've had something going on, especially in the abdominal region, and you've been to doctors and maybe even other PTs, and it's just like, this is just something that's not going away, I would encourage you to find a pelvic health therapist, because, if they're trained correctly, then we have a lens that can kind of dive deep and in and out to help try to figure out exactly what's going on. And we really are kind of the people that sometimes we're like the last step. Like I've seen everybody and I was sent to you, and we don't mind that. I don't mind the complicated. I know Roxy doesn't either. In fact, when I get that complicated, and then I might refer him to I have a functional nutritionist that I work with that is amazing and lovely. And a couple of people I've been like, okay, I think this would be a huge thing for you as well. And so I'll send them on, and I get complicated. I send complicated out, and we are thrilled to try to help individuals that have a lot going on. So
we're not afraid. Bring it on.
Yes, that's right.
I would just circle back to, we talked about at the beginning in your in the definition that you read, Megan, of manual therapy modalities, therapeutic exercise. So if we just circle back to that and thinking about what does all that mean, basically, we just kind of talked about we hit the tip of the things that we're looking at, and we're just trying to help you understand how your body's all connected. And so when we see something goes awry and it's not right, then we're going to treat it. And some of the strategies in our tool belt then we use our hands to treat it. That's manual therapy. We use our hands or tools, or, we try and manipulate the physical body in a way that promotes it to heal and correct and get back on board. We use exercise then, whether we need to lengthen a structure or we need to strengthen it or we need to coordinate it. We practice. We do that, with exercise. I'm just trying to think of some of the other functional training, that might be body mechanics, that might be piecing apart your day and helping you, restructure habits, sleep hygiene, just things like that, is some of those functional train. Megan, is there anything I'm really missing in there?
Yeah, it's just so all encompassing. Like you mentioned, the sleep, nutrition, water intake, behavioral strategies, like you've said, changing different behaviors throughout your day. But listen, the hardest thing for any of us is behavioral change. We could tell you what to do all day long, but we have to change our behavior to do it. Might give exercises, stretches, but a lot of hands-on work, like Roxy said. And hands-on work could be things that we refer to as like tissue rolling or cupping or manual manipulation or mobilization, trigger point release, myofascial release, the list goes on. And I know some of those words sound like, okay, I've heard that stuff before. And really it's just, they are all just really good tools for us to use. So yeah. And then tying it all back into function at the end of the day, us being able to then transfer what's happening into your everyday activities. Because just because your symptoms start to get better doesn't mean the dysfunction is still not there. So as we start to see things improve as far as your symptoms go, we stay at it so that then we know that it's completely taken care of moving forward.
And I would say just because you can do an exercise really well doesn't mean that that's how your body's actually going to use that area of your body when you go to lift up your kids or you go to get out of bed or you carry your groceries in. And that can be a big disconnect of saying, oh, I can do this exercise. Like I can pretty much all my patients can do any movement I ask them to do, but to do it well and to do it in a way that corrects the dysfunction is not the case. If we mindlessly run through some of the things, then it doesn't serve our bodies. And so that's a lot of that retraining that we are talking about. And so that's a whole nother podcast, Megan.
That is a whole nother podcast. I think we probably recorded 3 podcasts worth episodes into one here.
Yeah, that's all right. Oh, well. That's okay. That is okay, no problem.
Very good. Well, we were excited for you guys to join us again today, and we look forward to talking with you next time. Please remember what you learn and hear on this podcast does not replace medical advice. These conversations are for educational purposes only. Please reach out to your healthcare provider with any questions you might have. Thank you so much for joining us this week on the Pelvis Project podcast. Help us continue the conversation by liking and sharing this episode with friends. And if you really want to do us a solid, leave us a review. If you'd like to follow us on social, check out the show notes for links. And remember, this week, take a deep breath and relax your pelvic floor.